Now, my topic, as I hope you can see, is on current trends in the medical management of endometriosis. This is an extraordinarily complex disease, and I don't intend to just talk about the clinical focus of medical management, but I hope that I will be able to introduce that with some of the background and to fill in some of the necessary understanding about mechanisms and so on with this condition as a prelude to talking about how hopefully we can better manage many of our patients with endometriosis in a medical manner. I do need, nowadays, of course, always to start my lectures by indicating conflicts of interest. In this world, those of us working in anything academic and medical do need to declare our conflicts of interest, and we all have them. And I just draw your attention to the bottom one of these, which says, I believe that open academic collaboration between the pharmaceutical industry and individual clinical experts is essential to the future understanding of endometriosis, which is a continuing enigma of a disease. I was fascinated when I started to research the background of the extraordinary foundation which we honour today, and to find out about Dr. Stya himself, who has been the major initiator of the great majority of the major concepts behind this foundation today. This man indeed was a visionary first and foremost, an eminent industrialist, which earned him the financial backing to be able to do an extraordinary number of things here in India, and to set up examples which are a torch for countries all around the world. He has left a legacy of excellence. He is a role model for us all. And today, I was most interested in seeing that he has, in fact, with his daughter, set up a university with a liberal arts background, but some very interesting focuses. Not surprising, in view of his background, is an emphasis on both engineering and business, but also on journalism and communication, critical issues in the modern world, but also design courses. And through all of this is a thread pointing to his particular awareness and interest in healthcare issues. I was intrigued to see that there is a Master's of Science in Clinical Research, a PhD in Biotechnology, degrees in Pharmaceutics and Novel Drug Delivery Systems, something that has always intrigued me, and a diploma in Pharmacovigilance, amongst other things. Very far-sighted. This is clearly an amazing man. I personally have been humbled by the invitation that I have to be here today, and I hope that I can raise sufficient stimulating issues for you in the spirit of excellence in clinical research and healthcare, which have been espoused throughout his life by Dr. Stya. So, I will try to focus a little on the challenges and to challenge your thinking skills. Endometriosis has often been called the enigmatic disease. If you look up the shorter English dictionary, there are a lot of different definitions of the word enigma, but in general, it means that this is something that is very difficult to understand. And this is perhaps of all the gynecological conditions, the most difficult to understand in our present terms. This is still a mystery disease in spite of much research, mainly so far done in the Western world, but I'm delighted to see increasing amounts of academic pursuit and attempts at understanding many aspects of this disease in the whole world. I see this as a suitable target for the philosophical ideals and the excellence in research principles purveyed by Dr. Stya Paul. Now, first of all, what is endometriosis? Endometriosis is the presence of tissue with histological similarities to the endometrium, but outside the uterine cavity. This tissue in these ectopic lesions is functionally and architecturally quite different from the endometrium inside the uterus. So this is not external endometrium. This is a different condition. These are different tissues. And additionally, the endometrium from women with endometriosis is also functionally different from the endometrium of women without endometriosis. And the genetic and the molecular pathway complexities are fascinating, they're unique, and they're the subject of major ongoing research programs. And I'm going to be very selective and demonstrate my own personal biases in some of the examples and the ways that I'm going to look at this condition. Endometriosis is an extraordinarily variable condition. It's variable in the age of onset, in the constellation of presenting symptoms. There is always a symptom complex that accompanies the pain or the infertility, which are seen as perhaps the two main symptoms accompanying this disease. It's variable in the types and the severity of pains that the woman describes, variable in the site, the type and the extent of lesions and their pathology. It's variable in response to treatment, in the rate of recurrence following even excellent surgery, variable in the molecular pathway activations and pathophysiology. And it's influenced by multiple gene activations and modifications. There is now a huge literature expanding almost daily on the genetic background of this disease, but it is still as mysterious as ever from the genetic perspective. And you will see these four letters, GWAS, frequently appearing in the genetic literature. These are genome-wide assays looking at gene activations within the tissues associated with endometriosis. And so far, they have just provided us with increasing complexity in terms of trying to understand the pathophysiology of this disease. But it would be very surprising if we don't see an explosion of fascinating data about this condition over the next decade. Now, there are a whole range of what I see as current issues in the biology of endometriosis. I've talked a little about the complex genetic susceptibility. For example, if out of any of the women in this audience, if you have a sister with endometriosis, you have an 8-fold risk of developing endometriosis yourself. That's huge. If you have a mother with endometriosis, then you and your sister each have an approximately 8-fold chance of developing this disease. So there is major familial influence on the background. There are external environmental influences. We know that reproductive events influence the appearance and perhaps the severity of the disease. There are changes in cell-mediated and humoral immunity. So not just local immune changes within the lesions or within the endometrium of women with endometriosis, but also in the bloodstream. This is a systemic disease which we have not really recognized as such in the past. Therefore, there are roles for the cytokines, the chemokines, and other molecular regulators released by immune cells and also other cells in the reproductive tissues. There are roles for angiogenic and neurogenic factors because vascular development, angiogenesis, and nerve development are clearly a part of this disease. There is a complexity of all the various different molecular mediators. We're only really just beginning to scratch the surface. There are factors responsible for pain generation, but again, we're only just beginning to understand their complexity. There are factors responsible for infertility. Almost anywhere we look, we find that the molecular disturbances could be playing a role in influencing infertility. And of course, we need then to start coming to the roles of different medical and surgical therapies. I would also draw your attention to a small number of thorny issues which we're trying to wrestle with at the present time. The first being that endometriosis is a chronic inflammatory disease. We've always known that immune cells were a bit disturbed, or numbers of immune cells were changed in the tissues affected by endometriosis. But little did we understand that this really is a chronic inflammatory condition where there are major changes in the immune system, both locally and systemically. There's also the concept that perhaps endometriosis may primarily be a disease arising from the endometrium, because the endometrium of women with endometriosis is indeed quite different in the way it functions and the way the molecular pathways are set up compared with the endometrium of women without the disease. We've talked about the differing genetic origins, the multiple gene disturbances. I've talked about pain processing, but it is complex and highly variable between individuals. There are indeed even a small number of women with quite severe endometriosis who may not experience any symptoms. They do not have pain that they recognize as pain, and fortunately many do not turn out to have significant infertility. And what is the difference between those and the women who have real problems? Not yet always clear. And if we then pass on to look at the different types of endometriosis, there is increasing evidence that there are probably three phenotypes, three different forms of endometriosis in terms of the pain and the symptoms and the infertility. And we start at the beginning. You can actually find pathological tissues within the peritoneal surface down in the pelvis in women who have no symptoms, but when you look in with the laparoscope, you see an apparently entirely normal peritoneum. If you do multiple biopsies and you have a good pathologist, you will frequently find pathological appearances of the lesions of endometriosis. So this can begin at a microscopic level. Whether that is a disease, whether it is an extension of a normal physiological phenomenon, which then needs to progress further before you can call it a disease, we do not yet know. But once we do meet our current definitions of endometriosis, that is the presence of these lesions in association with symptoms, we find that there is a disease that only affects the peritoneum in many women, the pelvic peritoneum usually. Sometimes that can go deeper and become more vascular, and that may then extend into deep invasive disease in the deeper tissues of the pelvis. Or sometimes, quite on its own, without any other type of endometriosis, you can get endometriotic cysts, ovarian endometriomas. And there is evidence that these are probably three different phenotypes of the disease, even though versions of all of them can be found in the same woman occasionally. So you can get combinations of the lesions. How do we compare and grade these lesions? Well, they undoubtedly influence the way in which you approach management, whether that management you choose is surgical or whether you decide that there is a place for medical management. So understanding this disease and its background is critical for deciding where we go in terms of trying to manage the disease. Those of you who've studied endometriosis will know that we generally try to grade it using the American Fertility Society recommendations, now taken over by the the American Society for Reproductive Medicine. But even though that gives you a really good reminder of what the pelvis looked like at your last laparoscopy, it does not help to predict how that patient will respond in terms of therapy, what her chances are of fertility, or any other aspect of the disease. And the only index that we have that does help to predict is the fairly recently described endometriosis fertility index proposed by Dr. David Adamson from San Francisco. And that is a very useful index for women who wish to retain their fertility and hope to predict their chances. Now, if we take a step back and look at the pelvis and look at the pathology, which is where the classical understanding of endometriosis came from in the very early years of the 1900s. And this courtesy of my very good friend, Professor Robert Jansen, who we sadly lost earlier this year. He did an interesting study with one of our really good pathologists, trying to understand what was happening with the pathology of endometriotic lesions on the pelvic peritoneal surface. And in the top left-hand corner is a classical view of a red flare lesion, what we now know as a very active lesion with ongoing angiogenesis, so new blood vessels growing in from the outside. Those are the red stripes. In the middle is a reflecting white surface where there is already a bit of scarring developing, and we biopsy that area of angiogenesis. And bottom right, you can see the classic appearances of both the epithelium and the stroma, which have great cellular similarities to the endometrium, but of course the architecture of the tissue is quite different from the endometrium. We can look at other areas of the peritoneum, and you can see right in the middle of this a little papule. This, in most cases, we think is probably the earliest visible macroscopic appearance of endometriosis. And if you biopsy that papule in the middle, on the right-hand side, you see the pathology with the epithelium and the stroma of endometriosis. And as I mentioned earlier, if you biopsy areas that are well away from the obvious lesion, perhaps at the very bottom of the left-hand part of that slide, where it looks like normal peritoneum, you frequently will find pathology suggestive of endometriosis. And in one study carried out in the 1980s, they found evidence of peritoneal endometriosis in 18% of women who were coming for reversal of sterilization. So these were women who'd proven their fertility previously, wanted to have more children, and there was no evidence of any other features to suggest they would have infertility, but biopsying the peritoneum in 18% of cases demonstrated microscopic endometriosis. So this disease is a puzzle from the very earliest microscopic changes, which may get worse, they may resolve completely. There's a little bit of evidence for both of those in some cases at some times. And you also need to think about how long does it take to develop endometriosis, even if you've got very strong genetic predisposition. And if you think about it, in a woman who has got a strong genetic predisposition, and if you think about the pathology of this disease probably being retrograde menstruation of cellular fragments, little bits of viable tissue that may eventually stick to the surface of the peritoneum and grow and form lesions, it must usually take many, many months of repeated exposure to these viable cells or viable fragments before the disease actually becomes something that you can recognize pathologically. And certainly somewhat longer, even though we can see the worst forms of this in women still in their adolescent years. Of course, with these 4 examples that I show you here, these are much more advanced diseases involving the ovaries and the deeper tissues of the pelvis. But exactly what influences these, how they're influenced, and how it then influences the choices that you make for medical management is something that we still do not fathom. The World Endometriosis Research Foundation has been very active in recent years, particularly at the times of the triennial World Endometriosis Congresses, and it has made major attempts to try and define how researchers into this disease can ensure that we all define the disease in the same way, that we describe it in the same way, and that we do certain things that are systematic from one study to another, so that we can compare studies and begin to understand this very puzzling and individually variable disease. The current gold standard of endometriosis, of diagnosis of endometriosis, is, of course, to use the diagnostic laparoscope and to biopsy possible lesions, and to have an experienced gynecological laparoscopist be the person who is looking down the laparoscope. We can get some additional information prior to laparoscopy by using transvaginal ultrasound, particularly for ovarian cysts, and with developments of the latest technologies and good quality ultrasound experts, we can begin to define, using both transvaginal, rectal, and even putting fluid into the rectum, to try and define the extent and the outgrowths of the deeper disease. Top right here, you see a classical ovarian endometrioma, and you see color Doppler definitions with the color streaks around the margin of that cyst, indicating that this is quite a vascular cyst. On the right-hand side at the top, you can see a lesion in the wall of the bladder that's extended into the bladder cavity. Bottom left is complex disease involving bowel, and on the right-hand side is, if I can get the arrow, you can see tiny cysts with modern disease, which may be important in terms of your planning surgical approaches. Anyway, what about the accuracy of our ability to diagnose this disease? There are now probably about 7 or 8 studies in the literature looking at how good we are at diagnosing this disease, and they come out with very different positive predictive values as to how good we are at looking down it. And those values vary from 25% up to 100%. And this is in a good systematic review. And if you look for histological proof of disease that has been visually diagnosed as being endometriosis, even the best experts cannot get better than a 75% accurate assessment of lesions on the surface of the peritoneum. We're not very good at it. One study done in Italy, but also part of it in the United States, got 3 experienced gynecologists who looked at 91 lesions, and they each looked at the 91 lesions, and they each made their note as to whether they thought it was endometriosis or not endometriosis. And the guy who did worst only got 42% of those lesions right when he looked at them through the laparoscope. The best one got 76% right. And in another study, where 5 gynecologists experienced at laparoscopy looked at 1,439 lesions, they found that they, between them, did not get better than 50% in assessing peritoneal lesions. But they were much better, around 80% accuracy, for more serious, more advanced cases of the disease. So we're not good at picking peritoneal endometriosis and distinguishing from other variations in the macroscopic appearance of the lesions on the pelvis. And in fact, in that last study, they concluded visual diagnosis of endometriosis is generally unreliable as a primary diagnostic method because at least 1 in 4 biopsy specimens in our study did not meet the histological diagnostic criteria. So in order to assess this disease, you need to biopsy peritoneal lesions, but you may be much better at picking and understanding the more advanced disease. Now, I mentioned earlier, endometriosis usually is associated with a complex of symptoms, different types of pain, disturbances of bleeding, frequently extreme lethargy, especially at the time of menstruation, and all sorts of things like low-grade fever feelings, low resistance to infection, so coughing and sometimes getting the appearances of urinary tract infections. Gastrointestinal symptoms are greatly overlooked by gynecologists. Similarly for urinary tract symptoms, and of course there are sometimes genital tract bleeding disturbances, and we do know that sometimes women with endometriosis in unusual parts of the body can have bleeding from bizarre situations, such as coughing up blood once a month at the time of menstruation, or even having endometriosis on the pleura and developing a pneumothorax once a month. Real rarities that all the medical students know about, but when you encounter these, they can be difficult to deal with. So this brings me in the latter part of my talk to look at endometriosis and how we go about the potential of using medical management for controlling the symptoms of this disease. I'm not going to talk much about infertility because we believe there is very little place for medical management in women who wish to become pregnant at that particular point in time. So the best approaches for management of infertility are through IVF and its various other ART variations, or in some occasions undertaking certain types of surgery prior to moving to ART and so on. But with more and more experience in recent years, we're tending to move away from surgery, and we're tending to move to ART for infertility and medical management for prevention of recurrence of the disease following good quality previous surgery, or prevention in the very first instance where you suspect a woman may be developing it, perhaps because she's got a very strong family history. So I will from time to time mention prevention. So, management principles and endpoints of treatment. Obviously, symptom relief is a key part of this, and the major symptom that women find difficult to manage is pain. There are other symptoms, as I've mentioned. Infertility I've touched on, and I emphasize here the prevention of recurrence. But an important part of management has to be good quality analgesia in a way that the woman can understand, and hopefully that you can fit in to the particular cultural background and the healthcare system and what it allows you to do. And then, of course, we want to use hormonal suppression to minimize recurrence, to minimize further progress of the disease and to help relieve symptoms. And surgical excision there may still be a significant role for. What about actual treatment? We're becoming more and more aware of the variability of this disease, and therefore the need to individualize your management to the particular woman who is sitting beside you in the clinic. And sometimes this may result in you just observing this woman and not particularly undertaking active management. Less and less is that likely to be our route these days, but sometimes there may be a place for it, and sometimes it may be a choice of the woman not to take whatever therapies you're offering her. Effective analgesia, and then we move on to the actual active medical therapies. Many modalities, which I will come back and talk about. There are now a large number of Cochrane collaboration systematic reviews looking at different approaches to active management of women using medical therapies. And there are some new and some exciting looks into the future for where we may be going with medical management. We are starting to look particularly at combinations of medical management and the fertility treatments I have touched upon. Endometriosis and pelvic pain, well, we know that the two are associated very often, but often that relationship is unclear. There are multiple other causes of pelvic pain, and they should not be forgotten, even though endometriosis, we believe in most societies, is the commonest form of the commonest cause of pelvic pain in women in the reproductive years. But other causes are not uncommon and should not be forgotten. And most cases, interestingly, most cases of mild or minimal endometriosis are often not associated with severe pain. The deep invasive diseases, or the deep invasive types, the phenotypes of this disease, are the ones that are generally most painful and most tender to touch. Don't forget about the woman's sleep quality, something that we as gynecologists rarely pay attention to. Why should we worry about our patients' sleep? Well, it's probably part of the way in which their pelvic pain symptoms are enhanced. If you're short of sleep, if you have a chronic sleep debt, you tolerate pain much less effectively. You don't handle it in the same way. Chronic pain interferes negatively with the quality of sleep. Sleep disturbances contribute to the onset of pain, whatever pain that is, that includes endometriosis, and to a lowering of the threshold for pain perception at some body sites, and it probably includes chronic pelvic pain. Sleep quality was significantly poorer in women with endometriosis than in women without that disease, and there are ways in which one can approach this. Very little has been done in the field of endometriosis, but in other chronic pains, exercise usually helps. Sleep education, working out with the woman maneuvers that she can do that will help her to get in the right frame of mind to sleep and to stay asleep. And melatonin, that hormone from the pineal gland that some of us take for jet lag, melatonin may in fact improve sleep quality for women with endometriosis pain. Now, there's a lot of literature on treatment of pain in different ways. I want to start with a surgical treatment, even though my remit is to talk about medical management, because there is still uncertainty about how you go about managing the disease and minimizing the pain that the woman is experiencing. Now, this is the first study that was done in a proper scientific manner by Dr. Chris Sutton in the United Kingdom, published in 1994, and he did a double-blind, randomized controlled trial of laser laparoscopy with expectant management, which was just a diagnostic laparoscopy and recording of the appearances and the symptoms, and a third person who was blinded to what went on in theatre was the one who did the ongoing assessments after the surgery. So it was a properly done study. 63 women with pain and minimal to moderate endometriosis, a 6-month follow-up with another laparoscopy, and significant pain relief after the laser treatment in over 60% of the women, compared with around 20% of those who just had a diagnostic laparoscopy. And this pain relief persisted in 95% of those women who got benefit through to at least 1 year of follow-up. Interestingly, the least relief was obtained with minimal disease. And actually, the disease progressed in 35% of the untreated group. So this disease does usually benefit greatly, even in the relatively short term, from some approach to prevention of recurrence. This is using a standard pain score, a visual analog score on the vertical axis, before at 3 months and at 6 months. The laser treatment was with the closed circles, the black dots. So on the left-hand side, you see the pain scores before treatment. They both come down, even in the expectant treatment group, come down at 3 months. That's the placebo effect. But the placebo effect tends to wear off in 2, 3, 4 months. And so by 6 months, there is no beneficial ongoing effect in the diagnostic laparoscopy group, but a further improvement in the group that had very careful laser laparoscopy. He then went on to look at the proportion of patients who had their pain symptoms alleviated. So on the vertical axis are the percentages of patients who got better in terms of their pain. And if we look across at the right-hand side, so if I can find the pointer, here we have the right-hand side with the hatched bar. This is the assessment at 6 months. 100% of the women with stage 3 disease, so this is relatively advanced endometriosis, 100% of those women got a significant improvement to that effective laparoscopic treatment. The stage 2 disease, that's the open bars. Come on, let me find this pointer. It's coming. We have stage 2 disease there. They improved, but not as much as the stage 3 disease. And if you look at the black bars, you see that those women with peritoneal endometriosis, stage 1 disease, relatively mild, even though they had troublesome pain, only 40% of them had significant benefit at 6 months afterwards. This is a difficult disease to understand. And we do believe that these 3 different types and different severity are in fact behaving differently. What about recurrences after surgery? The best surgeons used to say, all my patients get better and I can tell them that I cure them. Sorry, that's rubbish. Most cases of those particular surgeons was that they had emphasized to their patients so strongly that this particular surgery would be the answer to their pain, that when that pain came back relatively soon, they did not dare to go back to that same surgeon, and they go to somebody else. And so it's very difficult to get good follow-up. But there are a number of studies in the literature which show that it is much commoner than generally recognized. So there's a real need for active prevention of recurrence after good quality laparoscopic surgery. Nowadays, we generally go for excision rather than using vaporization with laser. Effective long-term follow-up is required, so you don't just see them at 6 weeks and then say back to your general practitioner. You see them at least occasionally. Dr. Paolo Vercellini has recorded recurrences as high as 15% per year after good quality laparoscopic excision, and no association of the rate of recurrence with the ASRM stage of disease or the active nature of the apparent lesions. Dr. Tandoy and colleagues recorded between 43 and 68% of women having had a recurrence of their pain by 5 years after their laparoscopic surgery. And the recurrence increased steadily with time after the surgery. So this is a disease which recurs pretty effectively and fairly quickly in most women, even after good quality surgery. Going along with this, management of the pain does require good quality analgesia. And this depends very much indeed on your healthcare system and the way in which you can approach this and work with pain clinics or other things in order to produce the most effective relief of pain. One of the things I'm going to talk to you about in terms of medical management of the patient with endometriosis pain is, in fact, getting the women settled on a constant dosage of a preventive hormone, usually a progestogen or a progestogen combination. And in those women, we can actually get the great majority well controlled, no matter how bad their disease was at the beginning. But from time to time, they start to get pain back again. And these appear to be flares. So you get a flare of the pain within a few days, and it's often triggered by some stress in their lives, but sometimes you can't identify what that stress is, but it usually is self-limiting within 2, 3, occasionally 4 weeks. And so somehow you've got to produce effective analgesia or further suppression during that flare. You approach chronic erratic pain in different ways. There's sometimes intermittent, predictable pain, sometimes at the time of ovulation, but of course very typically at the time of menstruation. Many women with disease close to the bowel, doesn't have to be on the bowel, but just close to it, can get troublesome bowel symptoms, painful bloating. Some women have to have a different wardrobe because of their bloating at the time of menstruation when they have endometriosis. And we're beginning to see that some women develop neuropathic pain, pain with damage to nerve fibers, which appears often to be related to multiple attempts at surgery. One of the other reasons why we should probably be trying to minimize the number of times that these patients come to surgery. Effective analgesia, well, we can initially start with the antiprostaglandin agents, the NSAIDs, usually using a double dosage for limited periods of time, and that often helps to get a flare under control initially. And sometimes we need to proceed to codeine, variants of the codeine family. Tramadol often again helps getting the acute flare initially under control. Perhaps further going to use of oxycodone, or even occasionally for the worst flares, morphine used on a very short-term basis. Neuropathic pain can be amongst the most difficult to manage, using drugs like gabapentin or pregabalin, and those tend to have more in the way of side effects, and women can frequently not tolerate them for long periods of time. And of course, occasionally for the worst flares, admission for intramuscular or intravenous analgesics. And sometimes we're seeing benefits in these situations with acupuncture or other physical methods, but many women don't get good responses to those, so it needs to be an individual exploration. So, what about the list of medical therapies? GnRH analogues have been used widely. We're using these less and less frequently nowadays. Danazol we used to use a lot when we had nothing else. It still is a really good drug to fall back on, provided that you keep an eye open for side effects, and particularly the more worrying ones with voice changes or hirsutism effects. But in Italy and in some places in Japan, they've been using vaginal administration of danazol, finding it has a much lower incidence of side effects. The combined oral contraceptive is used very widely. I don't use the combined oral contraceptive pill because I find it somewhat illogical to give estrogen to a woman who has an estrogen-sensitive disease. So I tend to use the progestogen side of things. And generally, I have used medroxyprogesterone acetate and norethistérone. Now we have Dienogest, marketed as Visan, or in some countries desogestrel, again marketed as a mini pill, but can sometimes be very effective in managing the ongoing pains of endometriosis, particularly once you've managed to deal with the acute initial pain, get that under control with a GnRH analog, perhaps danazol, and then maintain that with a progestogen. And I have, over the last 10 years, been moving more and more to use the delivery systems. The subdermal Nexplanon, or in some parts of the world, the levonorgestrel implants are available. They should work in the same way, although there's very little data. Or using intrauterine progestogen with the Mirena levonorgestrel system. But for the most severe diseases, most severe pains in these women who've tried a whole variety of different treatments and had some surgery, we see some of these really very difficult patient problems, and we have to use very much off-label approaches to try and understand how we can manage these pains without doing multiple surgeries and exacerbating some of the background of the lesions in these patients. And we've been moving towards particularly using combinations, using the levonorgestrel intrauterine system, either with the subdermal implant or using double Nexplanon, the double implant, or even adding two of those systems to some oral dosage of progestogen, which you can then, I guess, titrate, really, by increasing the dosage when a woman gets a flare. And we're going to be seeing much more written about these different approaches for the women with the most difficult disease. And at the bottom of my list here, you see the progesterone receptor modulators. And the progesterone receptor modulators are a very interesting group of therapies, which we're going to see more and more of in the next decade. I'm sure that many of you are aware that one of these, that is ulipristal, has been marketed in most countries in Europe and has been approved in the United States for treatment of symptoms with uterine fibroids. But ulipristal also usually has beneficial effects in managing the pain of endometriosis, and I'm sure we will hear more about that in years to come. I mentioned the combined hormonal contraceptives, which are generally pills, but of course we have patches and vaginal rings as well, and I particularly don't like them for theoretical reasons, but in most combined pills, the progestogen component is much stronger than the estrogen component, and therefore it often works quite well for managing relatively mild or moderate pain, but less often the more severe pains. So, the progestogens, for many years I've used oral progestogens continuously, often for many, many years. I have about 100 patients who've had at least 8 to 10 years of being on oral progestogens alone, without long-term side effects, without effects on bone density, or any other obvious long-term problem. And many of those women became quite desperate when another doctor took them off that therapy, and their symptoms began to recur when menstruation started again. So there's no doubt that for many women with endometriosis, sometimes really quite difficult symptoms, you can usually, with a bit of variation in the dosages and how you go about managing this, get good control. This is the list that I've talked about already. Little bit of data. This is a study, 34 women in the United Kingdom, laparoscopically confirmed endometriosis, doing another laparoscopy later, and studying both their bleeding pattern and their pain. And you can see here the orange bars are the visual analog score of pain, so high pain at the left-hand side before the women had a diagnostic laparoscopy at which the levonorgestrel intrauterine system, Mirena, was inserted, and you can see that there is a very effective reduction in pain maintained over the next 3 years in the group. Didn't work for everyone as an individual, and some it worked brilliantly, even better than this. And you can also see there is a reduction in bleeding. So many of those women had very light periods, which was probably also beneficial in helping to manage the pain. Dr. Paolo Vercellini, who has contributed a great deal, many publications to the medical and the surgical management of endometriosis, he carried out a randomized controlled trial of expectant management or levonorgestrel intrauterine system insertion in women who were having effective laparoscopic surgery. And in his group in Milan, they have some very good laparoscopic surgeons who technically can do a very good job. There were 40 of these women. They were randomized to either having a diagnostic laparoscopy followed for 12 months, having laparoscopic excision followed by 12 months of observation, or they had laparoscopic excision and insertion of the Mirena device, and at 1 year there was recurrence of moderate to severe dysmenorrhea in 10% of the women who had the Mirena system in place, but in 45% of the women who did not have the Mirena inserted after their laparoscopic surgery. And there is now increasing anecdotal evidence that inserting the Mirena device, probably even using an implanon or Nexplanon, or using oral progestogens, that you minimize the rate of recurrence of this disease after good quality surgery. We can also use the levonorgestrel system in adolescents. And again, there are more and more anecdotal papers coming out around the world about the use of the levonorgestrel system in young women. This is a study from New Zealand where they have extensive anecdotal experience in adolescents. They found mostly straightforward insertions. It's often surprisingly straightforward to insert a Mirena into an adolescent, provided she's sexually active. In those young women who are not yet sexually active, then we would usually do a brief general anesthetic in order to be able to insert the system. But this can produce dramatic improvement in their endometriosis pain, as well as treating heavy menstrual bleeding in those that have it, or, of course, being a good contraceptive. Now, the new development in oral treatment, oral progestogen treatment, in the last 2 or 3 years has been the introduction of Visan, that is the progestogen Dynagest, and this is really just to show you visual analog score and a very slow reduction in pain over a 12-week period in those women who were treated with placebo. And the lower bar is the rate at which pelvic pain with endometriosis improved in the women treated with Visan. And if you then go follow those up for, I think it was 3 years, more than 3 years, you can see that there is a continuing decline in the visual analog score recording of pain in those women who continued on Vizam for that whole length of time. So this looks like a good progestogen. Whether it is better than what we've had for the last 50 years, we do not know, because all the studies with Vizam have been against placebo and not against other comparators. Now, we believe that some of the reasons for these unusual pains and some of the difficulties of managing those pains in women with endometriosis come from the presence of nerve fibers, approximately 1/3 of which are sensory nerve fibers that appear in the endometrium of women with endometriosis, but are not present in women without endometriosis. On the left-hand side here, you can see a rather faint blue background with, this is obviously proliferative endometrium, and you cannot see any red structures within that. If we go to bottom right, you can see a thick red trunk at the bottom. This is a thick nerve trunk running along the endometrial-myometrial junction in a woman with endometriosis. We have never seen this in women without endometriosis, and we've looked at quite a number of hysterectomy conditions. Top right-hand side, you see those small nerve trunks moving up into the functional layer of the endometrium, something that we just don't see except on very few occasions in women without the disease. So there are unusual things happening with the nervous system in the pelvis in women with endometriosis. So this is just a list to remind you of the progestogens, the vaginal danazol, perhaps rarely aromatase inhibitors. They do have some troublesome symptoms, and most of those centers around the world that have done studies with aromatase inhibitors are no longer using them. It sounded like a good idea, but probably is not going to be beneficial. And then more and more use of combinations of hormonal therapy to prevent recurrences and to suppress the disease. Now, how do you manage patients who are resistant to all these conventional therapies and the surgery? Troublesome recurrences after surgery. Perhaps none of the conventional combined pills have suited a woman. Oral danazol or GnRH analogues have given her side effects. Non-medical therapies maybe have helped a little, but have not been sufficient to give her good quality of life. And so you need to move, of course, to effective analgesia, often using a pain clinic. And if you have a good pain clinic, then it's really valuable to use their expert input into managing these very difficult patients. And then moving to these combinations, these individual combinations, and individualizing the therapy. And we are now moving, in the great majority of these patients, to insertion of Mirena, insertion of Implanon or Explanon in the same patients at the same time, and finding absolutely dramatic results. We've had a total of 40 women who have completed at least a year or two of treatment. One of these is now on her fourth set of 2 delivery systems. 12 of those 40 women were teenagers with the most extraordinary disease, unable to go to school, totally disrupting the whole family, tried a whole variety of different therapies, and 4 out of those 12 got absolutely dramatic results in terms of no bleeding, no pain, and a very normal lifestyle resulting. The remaining 8 of those women did very well. They still had a little pain, but it was entirely manageable. And if we looked at at 30 out of the whole 40, we found marked improvement in 30 out of those 40. And do remember, these are women who we really could not control, or other gynecologists could not control, with standard approaches to therapy. We're not advocating this at all as a routine, but for those small numbers of patients who you find extremely difficult to manage, moving away from conventional therapies can be very valuable. Move away from that and look at final issues needing better understanding. We need to better understand the natural history of this disease and its variants. We need to undertake more effective assessment, classification of the range of different aspects of each individual woman's disease, predicting and managing treatment failures, planning or avoiding the need for repeat surgery, managing neuropathic pain, using long-term hormonal therapy, optimal management of infertility, use of newer medical and hormonal therapies, and of course all of this is bound together by more effective, good counselling and information. And you really do need to have that to bring things together, maximise the placebo effect, and keep an ongoing control of the symptoms arising from this disease. Now, we're procedural specialists. We get paid for operating, so we spend hours operating on endometriosis and minutes talking with patients. Should we not be spending hours talking with patients and their families and fewer hours operating? Good counselling and holistic management concepts ensure much more effective use and continuation of analgesia and hormonal therapies. And I do have one final slide which says, endometriosis is a systemic disease, and only when we recognise that and recognise the implications far beyond the reproductive tract and the recognisable lesions will we be able to manage this disease most effectively. Hormonal therapies and effective analgesia will play increasing roles over the next 1 to 2 decades. Approaches to prevention and prevention of recurrence of disease will become critical issues, and only a small minority of endoscopic surgeons will have the advanced skills and regular practice to undertake effective management of deep invasive disease. So, thank you very much indeed for listening.